Hey guys, what's up? It's Stephanie. Welcome back to my channel. So in the video today, I'm going to be doing a review for your PANCE exam for your Physician Assistant National Certification exam. I'm going to be going over renal, so any type of renal disorder or renal topics that are on the PANCE, I'll be discussing those. So hopefully this video is helpful for you. For those of you who are currently studying for your PANCE right now, whether you're in PA school or just graduated from PA school, congratulations, that's a huge step. So now you just have to pass the PANCE to become a certified physician assistant and start practicing in whatever specialty you want to practice in. Or even if for those of you who are currently in PA school during your didactic year, hopefully this video is helpful for you for studying for your blocks, for example. I know for us, they divided our blocks depending on what body system, so hopefully this video is helpful, especially for those of you who are covering the renal portion during your didactic year. And just anyone else who's watching this video, whether you're a nurse practitioner, medical student, etc., hopefully this video is helpful for you. Just real quick about me, I'm currently a practicing physician assistant in critical care medicine. I work in the ICU. I graduated in December of 2020 and I took my PANCE January of 2021. I have to say I passed, thankfully, the first try around, and I did do very, very well in the exam. So I will be going over my notes. So I will be looking down at my notes a lot. I'll also be discussing some examples of what I've seen in practice. That's kind of how it helped me also when I was studying. I watched a lot of YouTube videos, I listened to a lot of podcasts, and then practicing doctors or practicing PAs or NPs, which just kind of gave also their experience on seeing and treating the disease, also helped me kind of just more remember that disorder. So hopefully this video is helpful for you, just being that I've been practicing for about a year. I've actually been doing a PA residency, so I've been working about 6 days a week. So I've seen a lot of cases. So hopefully this video is helpful for you. If I have any mistakes, please comment below. I will also add a link in regards to what I use to pass the PANCE and what I recommend. So hopefully this video is helpful. I'm going to be looking down a lot, and that's because I'm going to be looking at my notes. Fortunately, I don't have everything memorized, but I do remember a lot of the things. Okay, let's get into it. So the first one's going to be renal, of course. This is definitely really important that you know whether you are studying for your PANCE or are even going to be a practicing physician assistant. It's really important that you know this. Okay, so let's go into just acute disorders in general for renal. So the first one's going to be acute glomerulonephritis, also known as your nephritic syndrome. So this is going to be due to an acute immunologic inflammation of the glomeruli that causes protein and red blood cell leakage into the urine. So acute glomerulonephritis. How I think about the glomerulus is kind of as a basket. To give a basket, any type of damage to that basket that causes even bigger holes in the basket is going to have, you're going to have more things leaking through it, right? If you have the basket, for example, or how I think about it is what I use for food, right? Those baskets, and I apologize, I forgot the name. So if you're cleaning your food in this basket, usually none of the vegetables will go through the holes, right? Because they're very small, just the water will go through it. But if this basket gets worn down, for example, then with time, the food is actually going to start going through those holes. And that's kind of how I think of the glomerulus. It's going to be this basket in the kidneys. It's not meant for red blood cells, which are really big, to sift through it. So when you start having inflammation or anything damaging that glomerulus or your little basket, that's when you start having leakage of your proteins, of RBCs, just these big things that aren't supposed to be leaking into the urine. So what are some of the etiologies of acute glomerulonephritis? So we think about IgA nephropathy, also known as Buerger's. This is usually found in your young males who have some type of history of an upper respiratory infection or a GI infection. And it's really important that you look for this in the question stem, because it's going to say it's going to be a young male that just got better from an upper respiratory infection or a GI infection. It's usually due to abnormal IgA immune complexes that get stuck in the kidneys and they cause injury. Other symptoms can be episodic hematuria, usually lasting about 1 to 2 days, status post an upper respiratory infection and or a GI infection. Diagnosis, you're going to do an IgA antibody. It's going to come back positive. Treatment for this is going to be with ACE inhibitors and prednisone, but usually causes permanent scarring, unfortunately. The other type of acute glomerulonephritis is going to be your post-streptococcal glomerulonephritis. This is an inflammation of the glomeruli, usually due to group A beta hemolytic strep. And usually with these patients, they're going to be presenting with a history of pharyngitis or an impetigo infection. Usually with these symptoms, you're going to see the Coca-Cola colored urine, hypertension, facial edema, also And diagnosis is going to be, you're going to do your ASO titers, anti-streptolysin titers, and they're going to be positive. On your urine analysis, you're going to see red blood cell casts, and treatment is supportive. You can also do antibiotics like things like amoxicillin. So once again, for these IgA nephropathy, it's going to be a young male with an upper respiratory infection or a GI infection, right? And then for post-streptococcal glomerulonephritis, just like it sounds, it's going to be an inflammation of the glomeruli due to group A beta hemolytic strep. And you're going to have the Coca-Cola urine, hypertension, facial edema, positive ASO titers, and treatment is supportive. You can also give them antibiotics like amoxicillin. The other one's going to be your membranoproliferative, either nephritic or nephrotic. This is going to be most commonly found in your non-diabetic adults. It's usually associated with cancer, lupus, hepatitis, and the next one's going to be your rapidly progressive glomerulonephritis. This is going to be a severe glomerular injury. The thing about this one, and the reason why it's called rapid, is because they have a very rapid progression to end-stage renal disease. So diagnosis for this is going to be a renal biopsy. You're going to see a crescent formation, and that's going to be usually the buzzword, your crescent formation. Treatment's going to be with cyclophosphamide, anticoagulants. You also have Wagner's granulomatosis. This is going to be associated usually with necrotizing vasculitis, and diagnosis is going to be a positive C ANCA. The other one you're going to see is Goodpasture's syndrome. This is usually a small vessel vasculitis of the kidney and the lung. This causes, with these patients, what happens is that they have kidney failure, hemoptysis, cough, dyspnea. Diagnosis, you're going to see an anti-GBM antibody. And then you can do a biopsy. You're going to see these linear IgG deposits. Treatment's usually supportive. You do hydrosteroids plus cyclophosphamide and plasmapheresis. So overall, for these glomerulonephritis, we've discussed all of them. They kind of fall under this umbrella, right? So how are these patients going to present? So the classic symptoms for all of these, and the way you're going to differentiate them is by the diagnosis, what you're going to see on the cast, right, on those biopsies, and also what's going to be the history or the patient presenting. But classically for all of these, they're going to be presenting with hematuria, so blood in the urine, hypertension, peripheral edema, azotemia, fever, abdominal pain, flank, oliguria. So what does oliguria mean? That means decreased urination. Diagnosis is going to be a urine analysis. That's what you're going to start with. You're going to see red blood cell cast, proteinuria, hematuria. Their GFR is going to be down. Their BUN and creatinine is going to go up. But the gold standard is going to be a renal biopsy to rule out all the other ones that we discussed. Treatment is usually self-limited, especially like in your patients that have your post-streptococcal glomerulonephritis or things like IgA nephropathy. For patients that have hypertension, hypervolemia, or edema, you can do something like loop diuretics, beta blockers, calcium channel blockers, and then of course your ACE inhibitor. Those are going to be the big ones because these are very renally protective. And then you can do steroids and cyclophosphamide. The thing about this one is you have to know which type it is, right? So like we said, IgA nephropathy, your burgers, it's going to be your young male, status post upper respiratory infection or a GI infection. It's going to be the symptoms that we discussed with these patients. Diagnosis is going to be, they're going to have a positive IgA antibody, and treatment is going to be with your ACE inhibitors and steroids. Then you have your post-streptococcal glomerulonephritis, a patient with a history of pharyngitis or impetigo infection. It's usually due to group A beta hemolytic strep, right? These patients are going to have positive ASO, anti-streptolysin titers, and red blood cell casts, and treatment is supportive, and antibiotics like amoxicillin treating the strep infection. You have membranoproliferative glomerulonephritis, which is going to be the most very commonly found in your non-diabetic patients, and it's associated with cancer, SLE, hepatitis, decreased C3, and then you have your rapidly progressive glomerulonephritis. This is going to be a rapid progression to end-stage renal disease. You're going to see a crescent formation on your renal biopsy, right? And then you have your Goodpasture's. This is just a small vessel vasculitis of the kidney and the lungs. With these patients, treatment is supportive, hydrosteroids plus cyclophosphamide and plasmapheresis. Okay, next one's going to be your nephrotic syndrome, most commonly found in children. We think about glomerular injury / damage that results in increased protein, albumin, that causes increased protein loss in the tubules. So you'll see a lot of protein in the urine. And that's kind of how I remembered it, right? Nephritic syndromes, It has an I, so it's going to be any type of inflammation, versus nephrotic. It has an O, so it's going to be any type of protein loss. If it helps you, that's good. That's what it helped me kind of how to differentiate these. So nephrotic syndromes are most commonly found in children. Most cases we think about, and the most common one, are going to be your minimal change nephrotic syndrome. And this is going to be the most common type, about 80% of cases of your nephrotic syndrome. Minimal change disease is more commonly found in your children between the ages of 2 to 8. And it's usually preceded by an upper respiratory infection or immunization. Usually they're going to be presenting with hypoproteinemia, right? Remember we discussed nephrotic, it has that O, so you're going to lose a lot of protein. So hypoproteinemia, proteinuria, they have a lot of protein in their urine, edema, and then they're going to have decreased urinary output. The other type you have is focal segmental glomerulosclerosis, most commonly found in your African Americans, obese patients, any patient that has a history of an IV drug abuse like heroin. HIV is a big one that I've seen tested on a lot. So focal segmental glomerulosclerosis, think about HIV. Your diabetics, and this one's associated with an increased rate of renal failure. You also have your membranous nephropathy, most commonly found in your Caucasians, ages between 30 to 50 years old. It's associated with cancer, hepatitis, syphilis, and lupus. And then you have your membranoproliferative, like we discussed, either the nephrotic, it's associated with cancer, lupus, hepatitis, decreased C3, an increased mortality rate or progression to end-stage renal disease. So the triad for nephrotic syndrome is going to be the following. The patient's going to be presenting with hypercholesterolemia, so LDL is going to be, HLD is going to be elevated, so hypercholesterolemia, hypoalbuminemia, edema. They're going to have decreased urine output, abdominal pain, weight gain. Why are they having so much weight gain? It's because they're retaining all this fluid. Why? Because they're losing all the protein, right? And they're losing all the albumin. So that's why they're going to be very fluid overloaded. Initial diagnosis for these patients, you're going to do a urine analysis. You're going to see massive proteinuria, usually greater than 3.5 grams. It's going to be very frothy with oval fat bodies. That's a huge one. If you do a biopsy of the kidney, you're going to see hypocellular minimal change disease, especially since we said the most common one, you're going to see minimal change disease. Also, loss of podocytes is going to be what you're going to see on your minimal change disease. Treatment's going to be prednisone. This decreases inflammation. And the thing about this one, if it's not treated, it can lead to renal failure. In some cases, ACE inhibitors, calcium inhibitors. You're going to have a low sodium and protein diet with these patients. Complications that these patients are very prone for getting thrombosis, DVT, or renal vein thrombosis, and very prone for getting end-stage renal disease. Okay, acute pyelonephritis is the next one. This is going to be an inflammation of the renal pelvis. It's usually also known as an upper urinary tract infection, kidney infection. It's usually due to an ascending urinary tract infection that has progressed from the lower urinary tract to the upper urinary tract. Usually the patient's going to be presenting with more unilateral pain than, it's usually going to be more unilateral than bilateral, and very commonly found in women. Patients that have a history of indwelling catheters. That's why in our ICU, we assess these patients daily that have catheters to see if we can remove them. Very commonly found in pregnancy, in your children. Also, if you suspect UTIs or pyelonephritis, we think about your vesicoureteral reflux. Also via bloodstream from patients with a history of IV drug abuse and or endocarditis. The most common organism associated with urinary tract infections and pyelonephritis is going to be your E. coli, your gram-negative E. coli. It's about 75 to 95%. Of course, you have other causes like Proteus, Klebsiella, Pseudomonas, but by far the most common one is going to be E. coli. Make sure that you know that it's going to be a gram-negative bacteria. How is this patient going to present? They're going to have fevers, chills, dysuria, which is painful urination, CVA tenderness, so you go in their back and you percuss in their back, and they're literally going to jump off the bed because there's so much pain when they do that, when you do that to them. They're also going to be presenting with flank pain, nausea and vomiting, tachycardia, suprapubic tenderness, urinary frequency, and urgency. Diagnosis, you're going to do a urine analysis. That's what you're going to start with. You're going to see positive leukocyte esterase, positive nitrites, white blood cell casts on microscopy. Definitive diagnosis is going to be urine culture, and we usually do these also in the ICU for drug sensitivity to make sure that the drug that we are giving is appropriate for the bacteria that's growing. And then with these patients, we're going to do a CBC. You're going to see leukocytosis, a CMP, just to make sure you look at their BUN and their creatinine and their GFR. You can also do a renal ultrasound just to look for any type of structural damage. And with these patients, treatment's going to depend, of course, on their symptoms. If it's mild, then for these patients, first line is going to be fluoroquinolones like ciprofloxacin or levofloxacin for 7 days. Second line is going to be oral Bactrim for 14 days. And then if the patient is having moderate or severe symptoms and they're admitted to the hospital, or just if they're in the hospital in general, for example, if I have a patient in the ICU and they have this, then with these patients, you're going to treat him with, if it's moderate, you're going to treat him with IV fluoroquinolones like ciprofloxacin or Levaquin for 14 days. Alternative is ceftriaxone, especially if the patient's pregnant. You can also do aztreonam. If the patient has a severe pyelonephritis, then you're going to do something like ampicillin and gentamicin. You can do Zosyn, meropenem, or cefepime. So the thing about this is that you need to know how to categorize a patient from mild to moderate severe pyelonephritis. So if it's a patient with moderate or severe, it's going to be an inpatient, like we said. Usually if it's an elderly patient, if the patient's septic, if they're pregnant, immunocompromised, renal failure, refractory pain, or if they have any type of obstruction, then you treat them as moderate or severe. This is very commonly tested, so make sure you know this. So once again, moderate or severe, you are going to treat these patients the following. It's going to be an elderly patient, sepsis, pregnant is a big one that I see tested all the time, pregnancy, immunocompromised, renal failure, refractory pain, and obstruction. And moderate IV antibiotics is going to be first line IV fluoroquinolones, something like ciprofloxacin or Levaquin for 14 days. If the patient's pregnant, then you're going to do something like ceftriaxone. You can also do aztreonam. That's a non-pregnancy. If it's severe, then you pull out your big guns, right? Ampicillin, gentamicin, Zosyn, meropenem, and cefepime. So most common bacteria for acute pyelonephritis is going to be E. coli. Okay, so the next topic we're going to go over is going to be nephrolithiasis, also known as your kidney stones. The thing about kidney stones is that you need to know which one is the most common type, what are the different types, what are the locations. Of course, depending on what location they are in is going to tell you what symptoms they present with. So just in general, the most common one that you need to know is going to be your uretrovesicular junction. That's going to be the most common location for a kidney stone. So etiology, these are just most commonly found in men. Usually if a patient has a history of dehydration, they're more prone to getting kidney stones. If they have a history of hyperparathyroidism, if you've seen my endocrinology PANCE review, we talk about hyperparathyroidism, patient presenting with your stones, right? Kidney stones, psychiatric overtones, which is going to be, they usually present with depression. And then you have Thrones, that they have constipation, etc. So kidney stones, we think about hyperparathyroidism, diet, right? Peptic ulcer disease, irritable bowel disease like Crohn's, previous stones, family history, any type of medication that makes them more prone to getting kidney stones, obesity, diabetics, and if they have a history of renal tubular acidosis. So we have 4 different types of kidney stones. We have calcium oxalate, struvite, uric acid, and cysteine. By far the most common one out of all of these is going to be your calcium oxalate. That's going to be the most common stone, very commonly found, like we said, in your patients that have Crohn's, peptic ulcer disease, gastric bypass, ileal resection, increased dietary oxalate, vitamin C supplements, and thiazides. Struvite is going to be your second most common one. This is about 10% of kidney stones in general. This one, in comparison to your calcium oxalate and just the other ones, this one's most commonly found in females. So struvite more commonly found in females, and why? It's because it's commonly associated with urinary tract infections, and females are more prone to getting urinary tract infections. These are known for causing the staghorn stones, right? They're coffin-shaped, very alkaline pH, so they have very high pH, and it's usually due to urease-producing bacteria, things like Proteus mirabilis that loves to produce this urease and very commonly causes struvite kidney stones. The next one's going to be uric acid. This is about 5% of all kidney stones, very commonly associated with patients that have a history of gout, so look for that in the question stem. Dehydration, also if they have any type of occupation that is outdoors, labor intensive, right, that makes them more prone to getting dehydrated, hot climates, summer, high protein diet. And then the last one's going to be cysteine. This is not very common. It's about 1% of all kidney stones, usually associated with patients that have cystinuria, especially your men that have this autosomal recessive disorder of cystinuria, and that's what is associated with these cystine stones. They're hexagonal shape and they're semi-translucent. So once again, just for repetition, because I say repetition is a key, kidney stones, the most common one's going to be your calcium oxalate, right? The second one's going to be your struvite. We think about females because you're associated with urinary tract infection, especially your Proteus mirabilis bacteria that are kind of good at producing urease. The second one's going to be uric acid associated with gout, and then cysteine is going to be your cystinuria, this autosomal recessive disorder. So how is this patient with kidney stones going to present? They're going to have acute onset flank pain, colicky pain. So they're going to say that they have this pain that goes from their groin to their loin or from their loin to their groin. CVA tenderness, like we discussed, where you palpate in the back and they literally like jump off the bed because it's so painful. They're going to be writhing in pain. It's very, very painful, very obvious when you have one that's coming in. They're having like nausea, vomiting, throwing up, hematuria, tachycardia. And diagnosis for these patients, you want to make sure you get your BMPs right, look at their electrolytes, their uric acid, their parathyroid, just to rule out the cause for the kidney stone. You can do a urine analysis, a 24-hour urine culture, especially if in a woman you suspect that on top of that they also have an infection on top of their kidney stone. You want to look for crystals and casts. You can do a KUB, so you can do a kidney, ureter, bladder, so basically an x-ray, your abdominal pelvis x-ray. Usually if it's radio-opaque, you're going to see these calcium oxalate and struvite stones. Intermediately opaque, you're going to see cysteine, and then radiolucent, which means it doesn't show up, it's going to be uric acid. How I memorize this one is that it's radiolucent, so it has a U, uric acid, if it helps you out. You can also do an ultrasound. Now the gold standard is going to be a CT without contrast. Do we do this in patients? Of course we don't. But that's going to be the gold standard. This reveals the size of the kidney stone, the site, the density, but of course it's contraindicated in pregnancy. So treatment for this, pain control, that's going to be your initial one because these patients are writhing in pain. It's very painful. So you can do PO or IV NSAIDs. You can do opioids also, things like morphine. You want to make sure that you're hydrating the patient, whether it's IV or oral, right? Alpha blockers like tamsulosin you can give them. If a patient is outpatient, they're presenting with a kidney stone and the size is less than 6 millimeters and they have no signs of obstruction, then usually with these patients you just give them pain control, give them fluids, right? And then just tell them to strain their urine to see what type of stones they have, and then follow up. But if the patient's an inpatient or they have a kidney stone that's greater than 6 millimeters and they have signs of obstruction, or they're pregnant, or they're having an infection or an anuria, which is already a huge sign that it's obstructing something in the kidney. So anuria means no urine. They're unable to pass it after 4 weeks. They have chills, fever, nausea and vomiting, dehydration. So all symptoms that the patient might be even uroseptic. So septic. With these patients, you need to do, especially if they're greater than 10 millimeters, they need some type of urological intervention. So usually they'll place a ureteral stent, they'll do a percutaneous nephrostomy, a lithotripsy, which is kind of just like shake the patient to break that stone down. Ureteroscopy removal. This is only if it's greater than 10 millimeters, right? If it's less than 5 millimeters, it's usually likely to pass by itself. Usually if it's greater than 8 millimeters, it's very likely that it's not going to pass. So usually these patients are going to need lithotripsy. So this is very commonly tested. So I'm going to go over it once more just in regards to the management for these patients. So first line is going to be analgesia. If it's less than 6 millimeters or 5 millimeters, it's very likely that the patient's going to pass it spontaneously, right? If it's greater than 8 millimeters, it's very likely that it's not going to pass. So these patients are going to need something like lithotripsy. If it's greater than 10 millimeters, they're going to need surgical intervention. So a ureteral stent or percutaneous nephrostomy, any type of surgical intervention to remove that stone, and also its location. And like I said, if a patient is having symptoms or they're pregnant or symptoms of like urosepsis, right, where they're becoming septic, then they need intervention also. Okay, so just in general, I wanted to go over the nephritic versus nephrotic once more because this is very highly tested, and like I said, repetition is a key. So nephritic, nephrotic. So nephrotic, right, it has the O. So these patients are going to have heavy proteinemia, about more than 3.5 grams per day, right? Heavy proteinuria, so a lot of protein in their urine. They're going to have a hypoalbuminemia, so decreased albumin. And since they have decreased albumin, okay, these patients are going to have a lot of edema. So they're going to have generalized edema. They're going to have hyperlipidemia and fatty casts in the urine, hypertension, and these patients are at high risk for getting an infection and thromboembolism, right? Why? Because they have decreased albumin. And usually the pathophysiology of nephrotic syndrome is usually due to some type of structural damage of the glomerular filtration barrier that causes massive renal loss of protein. So remember we were talking about the glomerulus being this little basket and it has all these holes in it, so all the RBCs and protein is able to pass through, which it wasn't able to pass through in a normal person like you and me. Nephritic syndrome, usually these patients are going to have proteinuria, but it's going to be very little, about less than 3.5 grams per day, not as high as your patients with nephrotic syndrome. They're going to have hematuria also with acanthocytes. They can have edema, but it's not going to be as severe as your nephrotic syndrome. You're going to see red blood cell casts in the urine, red blood cell casts in the urine, red blood cell casts in the urine. Oliguria, which means very decreased urine output, azotemia, hypertension, sterile pyuria. And usually the pathophysiology is that they have some type of inflammatory response within the glomerule that causes GBM disruption. Okay, so next topic we're going to go over is going to be over our acute kidney injuries, also known as acute renal failure. This is really important, something you really need to know, something I deal with every day in the ICU, especially in the era that we're living now with COVID patients. I saw this a lot in COVID patients. So we have different types of acute kidney injuries. We have pre-renal, which is before you get to the kidneys. We have intrinsic or intrarenal AKI, which is within the kidney. And then you have post-renal, which is after you get to the kidney. So it's kind of how I understand these. So pre-renal is anything before you get to the kidney. We think about things like hypovolemia, right? So the kidney is not getting adequate perfusion. They're not getting enough volume. They're not getting enough oxygen, right? Versus intrarenal is just an injury within the kidneys, right? Within the structure of the kidney, whether it's due to the glomerulus, like we discussed, the nephritic, the nephrotic syndromes, right? Acute tubular necrosis, any type of medication that is causing damage to that kidney itself. And then we think about post-renal. So this is injury after the kidney, so you've passed it. So something like in the ureters, right? That is occurring. There's something in the bladder or urethra, like we think about our kidney stones that get stuck in the ureters that can cause obstruction, and you can cause a patient to become infected, right? Or urine outflow is obstructed. We think about metastatic cancer, like any type of bladder cancer that starts encroaching onto like the ureters, etc., where the kidneys are not getting, the kidneys are basically, it's occurring after the kidneys and there's some type of outflow obstruction once more. So pre-renal AKI, like we discussed, that's going to be the first one. Injury before the kidneys, the most common form of acute kidney injury. It's the most common one that I see in the ICU because it's due to an infection. They're septic, they're hypovolemic, whether it's like hemorrhagic shock or just hypovolemic in general, which is the case on a lot of our patients since a lot of the patients are not eating. So it's due to decreased perfusion. So it's an absolute loss of fluid, whether it's hemorrhagic that we discussed, are they in DKA, right? Are they just vomiting? Do they have diarrhea? When I was in the ICU, I saw this a lot in our severe burn patients and the burn ICU. Things like decreased circulatory volume, CHFers, right? Congestive heart failure. Usually with these patients, we see that cardiogenic shock where the heart is just not working. It's not pumping blood or oxygen to the adequate organs. Cirrhosis, sepsis, like infections like C. difficile, okay? Decreased perfusion, so things like hepatorenal syndrome, hypercalcemia, medications like your NSAIDs, symptoms like of how is this patient going to present? Dehydration, fluid loss, renal hyperperfusion, hypovolemia. Diagnosis, you're going to usually get a course of BMP in your patients, right? You're going to see decrease in their GFR. This is due to decreased blood flow, so less blood is being filtered. You're going to get a urine sodium, which is going to be decreased. These patients are going to be oliguric, right? They're going to be producing very little to no urine. They're going to have an increase in their urine osmolality, which is going to be very concentrated, increased specific gravity, increased BUN to creatinine ratio. Usually their creatinine is going to be very high. Usually with these patients, what I do is that I look at a trend. So I'll start trending their creatinine levels, and then if I start seeing them like go from like 0.8, 0.9, 1.2, 2.3, 4 point something, and that's when I start getting worried. I'm like, do I need to start getting renal involved? And then of course metabolic acidosis. With azotemia, there's going to be less urine and creatinine being filtered out, and then of course you can have leukocytosis if there's an infection going on. Treatment is of course aggressive normalization of arterial volume, so fluids. That's usually what I do with these patients. I'll give them a bolus of fluids, and that's usually all they need. It's interesting because you give them a bolus of fluids, and the next day you look at their creatinine level and it like went down. Because sometimes all they need is just volume repletion, especially if they're in the ICU. If they've been vomiting because they're coming in with like diabetic ketoacidosis, or if they're septic, right? The thing about these is that they can produce to acute tubular injury. So once again, pre-renal AKI, most common form of AKI, due to decreased blood flow to the kidneys, decreased perfusion, usually hypovolemic. And treatment's usually just fluids. And then, of course, treating whatever is the underlying cause. So if it's sepsis, treat that. If it's cardiogenic, like heart failure or CHF, treat that. Then everything will normalize. Next one's going to be your intrarenal acute kidney injury. This is an injury within the kidneys. Anatomical structure. This is direct cellular kidney damage. It compromises filtration, reabsorption, and secretion. So once again, this is within the kidney itself. Causes of this are toxins like nephrotoxic medications, radiation, metastasis, sepsis, infections. This includes acute interstitial, so ATN, acute tubular necrosis, and then AIN also. How is this patient going to present? Asymptomatic. Sometimes if they do have symptoms, they can present with oliguria, which is very little urine, anuria, which is no urine whatsoever at all, and then confusion, hypertension, and edema. Diagnosis, we're going to have decreased GFR due to cellular damage, increased urine sodium because it's not being reabsorbed, decreased urine osmolality, which is going to be usually with these patients dilate due to impaired water reabsorption, increased BUN and creatinine, which is usually what you're going to see in a lot of these patients, decreased specific gravity. In the urine analysis, you're going to see proteins, blood, CAS, eosinophilia. Usually we want to get also renal ultrasound. And treatment is you want to treat whatever's causing it. If it's glomerulonephritis or vasculitis, then you're going to do immunosuppressants and plasmapheresis. So acute interstitial nephritis, like we discussed, this falls under the intrarenal AKI umbrella. So this is going to be presence of inflammatory cells in the renal interstitial space. This is immune mediated, so your own body is doing this when it's not controlled. Most common cause is usually due to medications, so things like NSAIDs, PPIs, penicillin, ciprofloxacin, vancomycin, sulfonamide, and rifampin, lymphoma, sarcoidosis, tuberculosis is a big one, post-infective pyelonephritis also. This patient is going to be presenting with a fever or rash, and the rash is going to be usually maculopapular, peripheral eosinophilia, oliguria. Diagnosis is you're going to see pyuria with white blood cell casts and hematuria with eosinophils. There's going to be a decrease in their GFR, increase in their creatinine, and you can do a kidney biopsy. Initial imaging also you can do is a renal ultrasound, and treatment is just to discontinue whatever caused it. So any type of offending agent, whether it was an antibiotic, whether it was a PPI, and then if the patient has severe renal failure, then you're going to do something like steroids. Next one's going to be your acute tubular necrosis. Once again, this falls under what? Intrarenal acute kidney injury. So with these patients, it's usually due to prolonged severe ischemia. This can also be due to severe cases of prerenal disease, like shock renal ischemia, ATN. Usually, like in our COVID patients, I've been seeing a lot of our ATN also. Most common cause of intrinsic is, so the most common cause of intrinsic AKI is acute tubular necrosis. We think about nephrotoxic medications like NSAIDs, contrast, right? This is why we're very careful in regards to scans, whether a patient's going to get a CT head with contrast or CT abdomen pelvis with contrast. Although now there's debate going back and forth on whether contrast actually does affect the kidneys. So with these patients, if the patient is actively hemorrhaging and you don't find a source, and then of course you're going to get to CT with contrast because it's going to save the patient's life. So you have to kind of weigh and see what's more important with these patients. In addition to that, amphotericin is known for acute tubular necrosis. That's why it's also known as your amphoterable, right? Also, ischemic causes, we think about sepsis, where they have decreased renal blood flow. Primary symptoms, usually they're going to present with oliguria, or even the opposite, polyuria, vomiting, diarrhea, blood loss, shock, altered mental status. You're going to get a urine sediment where they're going to have these muddy brown granular epithelial casts, and that's usually the buzzword for this one. It's going to be your muddy brown granular epithelial casts. There's going to be free epithelial cells, fine granular casts. On your labs, you're going to see hyperkalemia, hyperphosphatemia, BUN and creatinine ratio less than 20:1, and then a FeNA greater than 1%. You're going to see increased sodium. Best initial, though, is going to be a renal ultrasound. Treatment's going to be supportive, right? IV fluids. You're going to remove whatever nephrotoxic agent was causing your acute tubular necrosis. And then dialysis, especially if it's if they have any symptoms of fluid overload or if they have severe ATN. So once again, the key for this one is going to be your muddy brown granular epithelial cast and your acute tubular necrosis. Next one's going to be your post-renal AKI. So for your post-renal AKI, this is injury that occurs after the kidneys, like I said, in the ureters, bladder, urethra. Usually there's some type of outflow obstruction where the urine is not able to get out. So the thing about this one is that it has to be bilateral, right? So post-renal AKI has to be bilateral. If it's unilateral, then it compensates, but it has to be bilateral, right? So if there's an obstruction just on one side, then it can compensate on the other side. It has to be bilateral. Etiology, most common cause is going to be kidney stones and nephrolithiasis, like we discussed, history of cancer, metastatic cancer, trauma, BPH, cases where urine is unable to drain adequately. Symptoms is the patient's going to be presenting with urgency, frequency, hesitancy, weak stream, dribbling, incomplete bladder emptying, flank pain, history of stones, spinal cord injury. When we think about these patients, right, spinal cord injuries are the ones that I see a lot. History of BPH. These patients are going to be presenting with a decreased GFR, decreased urine osmolality, increased BUN and creatinine greater than 20:1 ratio, abnormal UA. You're going to see red blood cell, white blood cells, and crystals. And then you can also do a renal ultrasound in regards to your initial imaging study. Treatment is, of course, to remove what is causing the obstruction. If it's a cancer, then remove the cancer. If it's a BPH, then BPH. And then monitor for any type of post-obstructive diuresis also. So once again, just because these are so highly tested. So pre-renal is going to be inadequate perfusion, right? This leads to decreased glomerular filtration rate, so the kidneys are not getting perfused, they're not getting their oxygen, they're not getting blood. So the patient's going to be presenting with concentrated urine, low urine sodium, and low FeNA levels. Usually we think about our shocks, cardiogenic shock, hemorrhagic shock, sepsis. Now, in regards to intrarenal or intrinsic, usually with these patients, it's that they have some type of damage to the cells within the kidneys, right? This compromises filtration, reabsorption, and secretion, so they're going to have a high FeNA. It's usually due to toxins, drugs, infections, and hyperperfusion. And then post-renal is going to be an obstruction that occurs after the kidneys. This is where the urine is unable to drain adequately. We think about, like I said, kidney stones, the most common one, tumors, benign prostatic hyperplasia, BPH, any type of trauma. We said also our big one was spinal cord injury. Okay, so rhabdomyolysis is going to be the next one. This is going to be a skeletal muscle breakdown and necrosis that what happens is that it releases a lot of intracellular contents of the cells into the circulation. And so since it releases all of this, who takes care of it, who cleans the entire body of these toxins and everything that the cells are breaking down to? Well, the kidneys do. So they're sent to the kidneys, and the kidney just isn't able to keep up with all of this, so it causes an acute kidney injury. So etiology is usually intense physical exercise. Usually it's going to be your marathon runners, and that's how it's going to present. Also, diuretic abuse, extreme heat or humidity, trauma, crush injuries, patient with statins, right? We think about statins, rhabdomyolysis. And then also, in my case, like in my neck of the wood, since I work in the ICU, it'll be a patient that's been found down for a very long time. They present with rhabdo, whether it was from like a trauma or, like I said, a head bleed, anything like that. So with these patients, they're going to develop with acute kidney injury. You're going to see increased levels of myoglobin in the kidneys. And what happens is that this myoglobin causes tubular obstruction, and then the metabolites cause damage to the tubules. So the triad of symptoms, it's going to be your muscle pain, weakness, dark tea-colored urine, nausea and vomiting, oliguria, and fever and tachycardia. I saw this a lot when I was in the burn ICU. It was a lot of these patients with this tea-color urine with rhabdomyolysis, just due to like these burn injuries that they have. They're also going to be presented with nausea and vomiting, oliguria, fever, and tachycardia. The labs you're going to get creatinine kinase, which is going to be really, really high, and usually in these patients we'll trend them until they start going down. They're going to have an increased creatinine. Their urine analysis, you're going to see myoglobinuria, brown cast, and then you're going to look at an EKG and monitor for any type of arrhythmias due to electrolyte abnormalities. Treatment is conservative, so you're going to give them IV fluids and mannitol. Right? We're going to make sure you clean all those kidneys, so usually we'll just give these patients a lot of fluids. And then medical, you can give them something like sodium bicarb. This is going to help to alkalize the urine due to metabolic acidosis. And then you can give them insulin and glucose, especially if they're hyperkalemic. Okay, so next topic is going to be your chronic kidney diseases. So this is a subtle decrease in kidney function. Usually the patient's going to have a GFR or glomerular filtration rate less than 60 for more than 3 months, and that's going to be the key, a GFR less than 60 for more than 3 months. And usually it's irreversible sclerosis, and they have permanent loss of renal function for more than, if they have these symptoms for more than 3 months. So some of the causes of chronic kidney disease is usually, for example, if a patient has uncontrolled hypertension, and the reason why this causes chronic kidney disease is because it starts scarring the glomerulus. Also, if the patients are diabetics, right? That's one of the big ones. Why? Because diabetes causes increased pressure, causes hyperfiltration. If they have a history of coronary artery disease, lupus, rheumatoid arthritis, HIV, long-term use of NSAIDs, smokers, if they're older, very commonly found in your African Americans also. If they have any type of history of renal disease, interestingly now, there's a lot of studies in regards to acute kidney injury and why it's so important that whenever you see a patient, like in my neck of the wood in the ICU, that starts developing these acute kidney injuries, to get renal on board, which is a renal team or nephrology team, as quick as you can, or treat this acute kidney injury, because these patients can later, once they get discharged from the ICU, have consequences from this acute kidney injury and can develop chronic kidney disease. So especially in a lot of our COVID patients, if they survive our ICU stays, which is very, very rare, we're seeing a lot of this in these patients. Proteinuria, glomerulonephritis, sickle cell, hepatitis, malignancy, or obesity. Usually these patients, if it's early, they're going to be asymptomatic. What you'll see in regards of labs, you'll see increased urea. So if you do see increased urea, you can have nausea, loss of appetite, encephalopathy also, asterixis, coma, pericarditis, bleeding, and I've seen a lot of pericarditis in these patients that are uremic. It's very interesting. You hear that friction rub when you auscultate them. I've seen also uremic frost, where the urea deposits on the skin. It sometimes looks necrotic. It's really interesting. Also, you'll see hyperkalemia. So a lot of these patients are prone for getting cardiac arrhythmias, hypocalcemia. So you'll see renal osteodystrophy, weak and brittle bones, hypertension. Why? This is due to low fluid. So what happens with that? The body starts releasing renin, and then renin starts increasing the blood pressure. They'll have decreased erythropoietin, and erythropoietin is usually responsible for red blood cell production. So since you have very decreased to no erythropoietin, you're going to have decreased red blood cell production, so you'll become anemic. And this is known as the anemia of chronic kidney disease. Diagnosis, you're going to get their GFR. Usually, like I said, it's going to be less than 60 for how long? For more than 3 months. So this is usually stage 3A. You want to get a baseline BUN and creatinine, and that's usually when I have a patient that comes in, and for example, they're unconscious, I don't know nothing about the patient, which is mostly the case, and then I call the family, they don't know anything about the patient, and their creatinine's like 4.5, I want to know, is this acute or chronic? Usually it's chronic. I will look through their records and try to look like 5 or a few years back and try to look at their creatinine and try to get a baseline creatinine level. So that's why it's really important that you want to get a baseline BUN and creatinine level for these patients. You can get a kidney biopsy, and that's usually how it's confirmed. You're going to see glomerulosclerosis. You can do an ultrasound. When I did my nephrology rotation in PA school, we did a lot of ultrasound with these patients, and usually what you'll see is going to be in your renal ultrasounds, a small kidney with cortical thinning. Treatment's going to be low protein diet. You want to make sure that you preserve the renal function, right? Because the glomerulus, like we discussed, are responsible for just your kidneys in general. If you have too much protein, then they're not going to be able to keep up with that. You want to control any type of comorbid conditions. So for example, especially your diabetics, it's really important that you have strict glycemic controls in them. But medical wise, it's going to be your ACE inhibitors or ARBs. These are going to be first line, once again, for blood pressure control in your chronic kidney disease. Given vitamin D, erythropoietin stimulated agents, synthetic erythropoietin statins. Moderate to severe chronic kidney disease, usually these patients need dialysis, especially if their GFR is less than 15. And then usually, like in the ICU with me, they get dialyzed 3 times a week or every other day. So like Monday, Wednesday, Friday, or Tuesday, Thursday, and Saturday. So it's every other day. And or renal transplant, and that's going to be last line. All right, so next one's going to be your end-stage renal disease. This is going to be a terminal disease. This is due to chronic kidney disease. This is where they have complete loss of kidney function for more than 3 months. The most common cause is going to be diabetic nephropathy, and it's actually the leading cause of end-stage renal disease in the United States. Other causes, like we discussed, is going to be hypertension. Genetic causes, we think about polycystic kidney disease, glomerulonephritis, also long-term NSAID use, repeated urinary tract infections and or pyelonephritis can cause this. And diagnosis, the GFR is usually going to be less than 15. With these patients, you're going to need dialysis, so usually these patients are going to get dialysis access. Is usually done in the operating room, and they're usually done preferably while the patient is in stage 4 chronic kidney disease, and in patients that have a GFR less than 30. So usually these patients get dialyzed until they are placed on a kidney transplant list, and then they are eligible to get their kidney transplant. And then, like I said, AV fistula, it's going to be the first choice because it lasts longer with less complications. And the ICU where I work, since a lot of these patients have acute kidney injuries that require like continuous renal replacement, which is different from hemodialysis. Hemodialysis, you get dialyzed every other day. CRRT, which is continuous renal replacement, you get dialyzed like there every day. And we usually have the patient on that until their kidney starts recovering from the acute kidney injury, whether it is from sepsis, like we discussed, like hemorrhagic shock, CHF, etc. So with these patients, what we'll do is that I'll put usually like a line. It's like a catheter line. So I usually put it in the jugular or femoral. It just depends. So I'll place the line there, and that's just going to be transient. But of course, a patient that has chronic kidney disease and they're getting dialyzed for years, you don't want any of these central lines in any of their body because these lines are prone to getting infected. So usually in the ICU, we don't try to keep them for a very long time. And so that's why these patients need something long-term. So that's why these patients are going to need an AV fistula. So this one, it connects veins to a nearby artery, and it creates a large vessel with fast blood flow. And these are really cool. I'm not sure if you've ever heard with them. If you listen to your stethoscope and they have them, you just want to make sure that they have flow, and it's like, that's usually how you you hear them. So these are usually preferred at the wrist or elbow, usually distally. And they're required 6 months prior to dialysis because it's going to take time for it to mature. You can also do a catheter like we discussed. These are temporarily accessed, and these are patients that need dialysis, like I said, ASAP. This is the ones that we see usually in the ICU. And then the graft is going to be your second choice. This is an artificial tube between the vein and the nearby artery, typically in the bend or the upper portion of the arm, and it needs to be placed 2 weeks before its use. So just real quick to go into the GFR stages, because this is something that's really commonly tested, right? We have 1, 2, 3A, 3B, 4, and 5, right? So usually with these patients, a GFR that's going to be greater than 90, that's going to be stage 1. And with these patients, it's normal GFR or high GFR, right? I would say maybe I have a GFR of 1 on days where I'm busy and I don't drink any water and I'm like super dehydrated. Maybe I have a GFR of 2. but usually greater than 90, that's the majority of us. And then treatment for this one is usually observation, treat any type of reversible causes. And then you have your GFR stage 2. This is going to be between 60 to 89. Usually this is mildly decreased. And treatment for this is going to be observation, monitor the creatinine level, and attempt to control blood pressures and any type of other risk factor. If they're diabetic, control their hyperglycemia like we discussed. And then you have your GFR 3A and 3B. 3A is between 45 to 59, and 3B is between 30 to 44. 3A, usually it's going to be your moderately to severely decreased. And usually treatment for this is going to be observation, once again, monitor creatinine, attempt to control blood pressure and any other risk factors. GFR 30 to 44 is also known as your moderately to severely decreased. And these patients, once again, same treatment like 3AB. And then GFR or stage 4, your GFR is going to be between 15 to 29. With these patients, you're already making plans to create an access site for dialysis and then assess them for possible transplant. This is also known as severely decreased GFR. And the last one's going to be GFR stage less than 15. This is completely kidney failure. Usually you want to make sure you start renal replacement therapy. They have to be on dialysis, and then of course transplant list for these patients. And then just a mnemonic, because this is very commonly tested also, what type of patients or indication, what are the indications for dialysis? So I think about AEIOU, AEIOU. So A is going to be acidosis, so metabolic acidosis with a pH less than 7.1. Electrolytes, right, for your E, so if they're hyperkalemic with a potassium level greater than 6.5, that's refractory to treatment, or if they're having rapidly rising levels in potassium. Ingestions is going to be your I, especially if it's a dialyzable drugs like salicylates, lithium, isopropanol, methanol, and ethylene glycol. Usually the mnemonic for that's going to be slime. So S for salicylates, L is going to be lithium, I is going to be isopropanol, methanol, and ethylene glycol, slime. The O for the mnemonic in AEIOU is going to be overload, so volume overload that does not respond to diuresis, especially with increased oxygen requirements. U is going to be uremia, so elevated BUN with signs of uremia, such as uremic bleeding, encephalopathy, pericarditis, and neuropathy, and then serum creatinine that's going to be greater than 10. So some of the congenital and structural renal disorders, we think about hydronephrosis is going to be dilation of the renal pyelonephritis system due to urinary tract obstruction. You get distended calyces in the renal pelvis. Etiology is usually going to be obstruction of some type of obstruction that causes urinary pressure, right? We think about also BPH, so benign prostatic hyperplasia, external compression like fetus or patients that are pregnant, that you're having that baby that is just compressing there. But definitely the most common cause of hydronephrosis is going to be your kidney stones, so any type of renal calculi. And remember we discussed that has to be bilaterally, not unilaterally. Because if it's unilaterally, then it can compensate on the other side. It has to be bilaterally for these patients. And then for bilaterally for it to cause post-renal AKI, right? So I have a patient going to present with hydronephrosis. They're going to be asymptomatic. If they do have symptoms, they can have flank pain, groin pain, urinary tract symptoms like dysuria, pelvic pressure, post-renal azotemia due to long-term hydronephrosis, anuria. And then diagnosis, you're going to get a BUN and creatinine level. Initial one's going to be a renal ultrasound. This is where you're going to see dilated thinning of the renal medulla or cortex with these patients. You can do a CT scan, especially in your adults, to check for any type of stones. And treatment is just to relieve the obstruction, whether it's a kidney stone, right? You're going to do a nephrostomy tube, a ureteric stent. This usually props the ureter open. You can do pyeloplasty, surgical remake of the renal pelvis, and then a urinary catheter for any type of lower obstruction. Okay, the next one's going to be polycystic kidney disease. This is going to be a genetic disease. Is where the kidney contains fluid-filled sacs and the kidney gets larger than normal and you have decreased function over time. What you need to know about this is the etiology. It's usually autosomal dominant. It's seen in adults, and usually they're going to have a family history of this. So risk factors is going to be younger age, African American, male, hypertension, presence of polycystin 1 mutation, and then most of these patients unfortunately have end-stage renal disease by the age of 60. So how are they going to present? So early manifestation symptoms include hypertension. Later in life, they're going to be presenting with flank pain, hematuria, recurrent urinary tract infections, and kidney stones. Diagnosis, you want to make sure you confirm this diagnosis. You're going to do a renal ultrasound. This is where you're going to see multiple renal cysts. You're going to do a CT and MRI. This is going to be more sensitive. And then labs, you're going to do a CMP. So you're going to see increased creatinine, proteinuria, and renal insufficiency. Treatment's usually going to be supportive. A lot of these patients may need also kidney transplant, but you're going to make sure you control their blood pressure with ACE inhibitors and angiotensin receptor blockers, so your ACEs and ARBs. The goal is to get your blood pressure around 130/80. Dialysis, cyst drainage, and like I said, kidney transplant is going to be the definitive treatment. Now, in regards to complications for these patients, they're very prone to getting intracranial hemorrhage and Barry aneurysms. So they're very prone to getting aneurysms and these aneurysms rupturing and causing an intracranial bleed. Next topic is going to be renal artery stenosis. This is going to be an occlusive disease. It's due to decreased blood flow to the juxtaglomerular apparatus. Usually this causes renal vascular hypertension. So what happens is that you have narrowing of one or both renal arteries. If both are basically with these patients, if both of them are stenosed, it can progress to total occlusion, which can cause an infarction of the kidneys. Some of the causes are going to be atherosclerosis. It's going to be by far very commonly found in your older patients, your smokers, and then also patients that have a history of hypertension, coronary artery disease, hyperlipidemia, diabetes, and the other causes are going to be fibromuscular dysplasia, especially this is commonly found in your young females. This is something that's very commonly tested. So if you have a patient that presents, they're hypertensive, you're not able to control their hypertension, and they've been on multiple antihypertensive medications, then you want to maybe think about fibromuscular dysplasia, especially if they're young. What you're going to see is this beaded appearance. It's going to be involved usually in fibromuscular dysplasia, the distal renal artery, and it's associated with renal artery aneurysm. And like I said, with renal artery stenosis, you're going to have this refractory hypertension, especially with ACE inhibitors. So you have a patient that presents, it's going to be a young patient, they're on like 3 or 4 antihypertensives from different classes, max doses, and they're still not responding. Maybe you want to further investigate, right? Do they have hyperaldosteronism, or do they have something like renal artery stenosis? They're also going to have an abdominal bruit. That's going to be one of the buzzwords for these patients with renal artery stenosis: headaches, sudden hypertension, onset with family history, diastolic hypertension, especially in those patients that are younger than the age of 35. Diagnosis, you're going to see a decrease in their renal function, so you're going to look at their BUN and creatinine. But the gold standard for renal artery stenosis is going to be a renal Doppler and an arteriography. So treatment, if it's atherosclerosis, you want to do a statin and an antihypertensive medication like an ACE and ARB or calcium channel blocker. Goal is a blood pressure of 130/80. Aspirin, smoking cessation, and ACE inhibitors are contraindicated in bilateral stenosis. You have to know this. So bilateral stenosis, ACE inhibitors are contraindicated. And then in regards to revascularization, you can do percutaneous and transluminal angioplasty, also known as PTA. And then you can do a stent placement or surgical bypass of the stenotic segment. So once again, renal artery stenosis, a patient that has refractory hypertension. There are multiple antihypertensives. The hypertension cannot be controlled. They have an abdominal bruit, history of headaches, or even a history of Barry aneurysms. Especially in your young females, you're thinking about fibromuscular dysplasia. In your older patients, you're thinking about atherosclerosis. Next one's going to be your horseshoe kidney. This is going to be a fusion of the upper or lower kidney poles, trapping of the kidneys under your inferior mesenteric artery. The etiology of this is going to be a congenital abnormality, most commonly found in males due to chromosomal abnormalities. And usually the most common form you're going to see is lower pole fusion versus upper pole fusion, so just keep that in mind. Usually these patients are asymptomatic. They have a really good prognosis, but they are at increased rate for urinary tract infections, hydronephrosis, nephrolithiasis, and then abdominal fullness is what you're going to see on your physical exam when you palpate. Diagnosis is usually found incidentally on imaging, so you can start with the kidney ultrasound. You can do a voiding cystourethrogram, And usually with these patients, there's no treatment because a lot of these patients are asymptomatic. If they do have these UTIs, then of course treat them with antibiotics for urinary tract infection. So once again, just for these renal disorders, right, fibromuscular dysplasia, you're going to see what the beating. It's really, really kind of like pathognomonic for these patients. So fibromuscular dysplasia, you're going to see this beaded appearance. And the other type of flavor of renal artery stenosis is going to be your atherosclerosis in your older patients. So next topic is going to be your renal cell carcinoma. So let's go into the neoplasms. This is going to be the most common type. This is where you have a clear cell. It originates within the renal cortex. Most common kidney cancer in adults. It's also known as your silent cancer. Etiology, most commonly found in your older men, especially more than females, ages between 60 to 80. Risk factors are going to be smoking, hypertension, and dialysis, acute tubular necrosis, and it's very commonly found in your Alaskan and Native Americans. Usually they're going to present with hematuria that is going to be gross or painless, palpable mass in the flank, flank pain, weight loss, hypertension, and hypercalcemia. Usually in left side in your males, it's usually associated with varicocele. And then these patients can also present with paraneoplastic syndrome, which is going to be usually your polycythemia, hypertension, hypercalcemia, and Cushing's, right? The diagnosis for renal cell carcinoma, the best initial is going to be an abdominal CT with contrast. This is going to help you stage how far along and what stage they are in for the renal cell carcinoma. You can do an MRI also just to look at the inferior vena cava, chest x-ray to look for any type of metastasis, right? And you can do a bone scan also for metastasis and a chest CT. First line treatment is going to be a nephrectomy. It depends, of course, what stage they're in, whether you're going to do a partial, simple, or a radical. Also chemotherapy. Usually they're resistant though to chemotherapy, so it's not very effective. And usually these patients, they get referred to urology, right? So once again, renal cell carcinoma, it's most commonly found in your older men, especially between the ages of 60 to 80, if they have a risk factor of smoking, hypertension. And in regards to symptoms, hematuria. So if it's a patient that's older and they're having painless hematuria, you see on physical exam that they have this palpable mass. They've been presenting with weight loss, and think about renal cell carcinoma. So the next one's going to be your Wilms tumor. This one's very commonly found in children, and it's the most common malignant tumor in children, usually if they're less than 15 years old. So this is also known as your nephroblastoma. What happens is that there's an abnormal renal development and proliferation of mesonephric blastema. Most common solid renal tumor in children, like I discussed. It's associated with WT1 on chromosome 11. And then most of them are solitary lesions. Some can be bilaterally, but usually they're just solitary. This patient is going to be presenting with flank and abdominal mass and swelling, large, palpable, unilateral abdominal pain, fever, hematuria, and hypertension due to renin secretion. So if you have a child that presents, it's coming in, and they have hypertension, you kind of want to work that up, right? So hypertension is not very common in children unless there's a cause that's causing this hypertension. Versus your older patients, right, was very common. So diagnosis initial is going to be a renal ultrasound, and this is where you're going to look for tumor infiltration of the renal vein and IVC. You can do a CT and MRI to stage it, a chest x-ray, and a CT scan. You're going to check for metastasis, and then you confirm it with a renal biopsy. Treatment is you're going to refer them to a pediatric oncologist, right? You can do a pre-nephrectomy chemotherapy, but the initial treatment is going to be primary nephrectomy, right? Just to remove the kidney or a portion of the kidney. Usually these patients have a good prognosis when they're treated. So once again, renal cell carcinoma, older men, right? Painless hematuria, flank pain, weight loss. You'll have this mass in the flank. Versus your children, this is going to be your Wilms tumor. It's going to be the most common tumor in children. It's associated with WT1 on chromosome 11. Flank, abdominal mass and swelling, abdominal pain, fever, hematuria, and hypertension. There was a PA that I knew that actually missed this diagnosis on a patient, on a child that came in and missed the diagnosis. The child ended up passing away, and he ended up having to go to court. So it's really important that you are aware of this, especially in a child that comes in with hypertension, right? Hematuria, fever, abdominal pain. Do your physical exam, look at the flank. And abdomen and look for any type of mass or swelling. Okay, next one's going to be your fluid and electrolyte disorders, my favorite. Joking, but I see a lot of this in the ICU. So this is going to be a good review for me. So the first one's going to be your metabolic acidosis. This is going to be excess accumulation of fixed acids or excessive loss of fixed bases. So excess accumulation of acids, whether it's through metabolism that does it or ingested foods, or excessive loss of fixed bases. So etiology, we have two different flavors. We have non-anion gap metabolic acidosis, and then we have anion gap metabolic acidosis. So non-anion gap metabolic acidosis, usually these patients we think about GI bicarbonate loss, so things like diarrhea, renal tubular acidosis, carbonic anhydrase inhibitors, TPN or rehydration, and chlorine gas exposure. For your anion gap, usually if the anion gap is greater than 11 or 12, it depends, the ICU we say 12. We think about our mud piles mnemonic, right? We think about methanol, uremia, DKA, mud piles. So P, pearaldehyde, I is going to be isoniazide, L is going to be lactic acidosis, things like rhabdomyolysis, for example. E is going to be alcohol abuse, S is going to be salicylates. And then how is this patient going to present with metabolic acidosis? Kussmaul breathing, so they're going to have an increase in the respiration rate. Why are they having an increase in the respiration rate? They're trying to compensate for the metabolic acidosis, and they're trying to remove the CO2. They're going to be lethargic, drowsy, stuporous, coma. They're going to have a headache, flushed, dry skin, peripheral vasodilation, fruity breath, especially when we think about our diabetic ketoacidosis patients, nausea and vomiting, and convulsions. So I had a patient about a week ago. They had admitted for diabetic ketoacidosis. When he came in, his glucose was more than 1,000. I think it was like 1,200 and something. His pH was 6.8 and his bicarb was 2. So he was in florid metabolic acidosis. And of course, we ended up treating the underlying disorder, which was going to be, of course, the diabetic ketoacidosis. And on top of that, he had end-stage renal disease. So we had to connect him to CRRT, which is continuous renal replacement therapy, because he gets dialyzed. And we wanted to make sure that with him, we were managing his glucose, and we were trending ABGs, which are arterial blood gases, to look at the pH and look at the bicarb and the CO2. We were trending those and just resuscitating the patient like crazy. And then treating the hypokalemia. So what is the diagnosis with these patients? Like an ABG, which is what we did with this patient. The pH is going to be usually less than 7.45. Like this patient that I said, he had a pH of 6.8. Usually these patients have a normal PCO2. If it's 35 to 45, it means it's uncompensated, and their bicarb is going to be low, so it's going to be less than 22. Like I said, this patient had a bicarb of 2. And then treatment for this is going to be sodium bicarb and fluids, which is what we did for our patients. So sometimes if they're like severely metabolic acidosis because they're septic, for example, and the lactate's really elevated, sometimes we'll put them on a bicarb drip, sodium bicarb drip, or we'll just give them amps of sodium bicarb. Next one's going to be metabolic alkalosis. This is going to be an accumulation of fixed bases or excessive loss of fixed acids. So once again, you have acid loss like chloride, which causes an increase in your pH and an increase in your bicarb. So some of the causes of this is going to be, the most common ones going to be vomiting, nasogastric tubes or NG tubes, diuretics, hypokalemia, Cushing's syndrome, hyperaldosteronism. Why? Because you have an increased renal excretion of hydrogen, chloride, and potassium. This patient's usually going to be presenting with decreased respiratory rate and depth, dizzy, paresthesias, trousseaux, nausea and vomiting, irritability, convulsions, and coma. They're going to be severely dehydrated also. And then diagnosis, you're going to do an EBG. Their pH is going to be greater than 7.45. When we think about our pHs, right, 7.35 to 7.45 is going to be normal. So anything greater than 7.45, we think about alkalosis. Their CO2 tends to be usually normal. With these patients, with these patients with their CO2 tends to be normal. It's about 35 to 45. If it is 35 to 45, it's uncompensated. Their bicarb is going to be high. It's going to be greater than 26. Respiratory acidosis. This is usually due to inadequate alveolar ventilation that leads to CO2 retention. So they're going to have increased CO2 and then decreased pH that causes this acidosis. The most common cause of respiratory acidosis is going to be apnea or hypoventilation. Usually we think about our COPDers, right? that are not able to ventilate appropriately, so they're retaining all this carbon dioxide. So acute causes, we think about respiratory acidosis is going to be acute respiratory failure, whether it's a cardiac arrest or respiratory arrest, opioid overdose that causes respiratory suppression. With these patients, chronic causes, we think about COPDers, like I discussed, hypoventilation syndrome, like Pickwickian syndrome, and then congestive heart failure. And with chronic respiratory acidosis, usually the pH can be normalized or near normal, and the reason is because the patient is compensated and they've just been chronically having respiratory acidosis, so their body has already been compensated and they're accustomed. So how is this patient going to present? They're going to present with dyspnea, tachypnea, slow, shallow respirations, confusions, tremors, dizziness, convulsions, warm and flushed skin, ultramental status, which is a big one, loss of consciousness, and cyanosis. So look for those: ultramental status, cyanosis, dyspnea, and tachypnea. Diagnosis, you're going to get an EBG, and since it's acidosis, the pH is going to be low, so it's going to be less than 7.35. Since it's a respiratory, it's going to be the opposite, right? If the pH is low, the PCO2 is going to be high. So you're going to be greater than 45, where the patient is retaining carbon dioxide, but they're going to have a normal bicarb. If it's 22 to 26, I mean it's uncompensated. All right, respiratory alkalosis. This is going to be due to hyperventilation leading to carbon dioxide deficiency. So usually it's going to be hypocapnia. What happens is that you have this low carbon dioxide that leads to high pH that causes alkalosis. The most common cause is going to be hyperventilation. So we think about our patients that are anxious, right? Anxiety attack, panic attacks, if they're in severe pain also. In surgical trauma ICU, we have a lot of little older patients that get their rib fractures or just motor vehicle accidents with their rib fractures. So these patients are sometimes hyperventilated because they can't really take those nice deep breaths because it's very painful. So if they're in severe pain, pulmonary embolisms like PEs, central nervous system trauma or lesions can cause respiratory alkalosis, hypoxia, pregnancy, aspirin and overdose and toxicity. How is this patient going to present? They're going to have tinnitus or ringing in their ears, vertigo, dry mouth, blurred vision, rapid and deep respirations like I discussed, lightheadedness, paresthesias, syncope, convulsions, and coma. Diagnosis is going to be a pH. So this is an alkalosis, so the pH is going to be greater than what? Greater than 7.45. The CO2 is going to be low, so it's going to be less than 35, and the bicarb is going to be normal. If it's 22 to 26, that means it's uncompensated. So this is really important that you know, not only for the exam, but also just in general to know for when you practice, because I still struggle with these, as you can tell, so it's really important that you're familiar with these. So like I said, respiratory acidosis, usually it's hypoventilation. Usually we think about our COPDers or someone that just cannot breathe. In addition to that, we have respiratory alkalosis. This is the opposite, hyperventilation, or they're usually breathing way too fast, so we think about anxiety. We're going to trend all of these with ABGs. Metabolic alkalosis, vomiting by far is the most common cause of this. And then metabolic acidosis, we have our non-ionic gap and our anion gap. You have to know the difference between each one. Anion gap, we think is going to be an anion gap greater than 11 or 12, depending on what you're reading in the textbook and where you're practicing. Metabolic acidosis, we think about anion gap, your mud piles, right? Methanol, uremia, diabetic ketoacidosis, paraldehyde, isoniazide. L is going to be for lactic acidosis, also like rhabdomyolysis. E is going to be for ethanol, and S is going to be for salicylates. And then you have your non-anion gap, which is just where your gastrointestine is losing a lot of bicarb. So we think about diarrhea in these patients and also renal tubular acidosis. And treatment for these patients is going to be sodium bicarbonate fluids. All right, next one's going to be your hypovolemia, right? This is usually, like it sounds, decreased volume. So you have isotonic fluid loss from your extracellular space. It can progress to hypovolemic shock. Some of the causes of this is going to be excessive fluid loss. So we think about hemorrhage, patients that are just having decreased fluid intake, if they're dehydrated or third space shifting. And with these patients, they're going to be presenting with ultramental status. They're going to be very, very thirsty. They're going to be tachycardic. They're going to have delayed capillary refill, which is a really important physical exam that you learn. Orthostatic hypotension, decreased urine output, cool and pale extremities, and weight loss. Treatment is just fluid replacement, giving fluids. I know it's so simple and it sounds so simple, but really that is a treatment, which I was very surprised when I started working as a PA. The other one's going to be albumin replacement, blood transfusions, especially if the patient's hemorrhagic. And then also you can do dopamine to maintain blood pressures, but that's just textbook. Nowadays we don't use dopamine anymore. We actually prefer norepinephrine or levo, right? And epinephrine, not anymore dopamine. So if the patient requires vasopressors, then you're going to do something like norepinephrine. So the next one's going to be hypervolemia, which is going to be the opposite. This is where the patient has excess of fluid in the intracellular compartments due to fluid or sodium retention. And it's usually due to excessive intake or just because they have renal failure. So I have patients that come in, they're in end-stage renal disease or on CRRT, and then you look at them and they look like the Michelin Man, right? They're like super just edematous. Like you look at them, they have 3+ edema. You listen to their lungs and they just have like crackles everywhere. And then I'm a huge fan of ultrasound, like point of care ultrasound, and I'm trying to get better. So with these patients, I always like to look at their lungs with the point of care ultrasound. And usually what you'll see is going to be B-lines. And then what that means on an ultrasound when you see B-lines is that it looks like comet tails. And in a patient that has, when you look at their lungs with an ultrasound, multiple comet tails, more than 3 in their lungs, that's usually a very specific sign and sensitive for hypervolemia or a patient that is just fluid overloaded. And so in conjunction to what I see on my ultrasound and then on my physical exam that they have 3+ pain edema and they look like the Michelin Man. And then on top of that, you're listening to the lungs and they just like have like crackles or like they sound roncorous. And that's like a huge sign that they're hypervolemic. So if they're on continuous renal replacement therapy where they're getting dialyzed, maybe I want to increase the ultrafiltration rate, right? Maybe I want to remove more fluid. If they're at 200, maybe do 300. I can diurese them with the diuretic, right? Lasix is the one that we like to use a lot in the ICU. So etiology, this usually occurs when compensatory mechanisms fail to restore fluid balance. It leads to, like we discussed, pulmonary edema and congestive heart failure. What you're going to hear is tachypnea. This patient is going to be presenting with signs and symptoms of tachypnea. If they're not intubated, majority of my patients are intubated. Dyspnea, what you're going to hear, like I said, is crackles on your physical exam. They're going to have this rapid bounding pulse, hypertension, S3 gallop. JVP, I have to be better at that. I don't look at that a lot. It's something I have to assess better with my patients. Acute weight gain and then edema also, like I discussed. You can also measure their CVP. So usually their CVP is going to be increased. We don't do that in the ICU anymore because there's been studies going back and forth in regards to how effective it is. But like I said, you can look at their pulmonary artery pressure and pulmonary wedge pressure, especially if they have Swan-Ganz, but we don't do that anymore in the ICU because Swan-Ganz catheters are not very specific and they're very invasive. Fluid. So treatment for this is going to be fluid and sodium restriction, right? If your patient is fluid overloaded, if they're not like my patients that are intubated, if it's just a regular patient like on the floor, then this patient, what you want to do is fluid and sodium restriction. Diuretics, like I discussed, give him Lasix, give him 40, give him 80. How much do they respond? And then you want to monitor the urine output. Usually with these patients, I try to keep them net negative. So what that means is that I'll look at their urine output or just overall, like their intake and urine output and see how positive or negative they are. I try to keep these patients like -2 liters or -1 liter. Listen to their breath sounds and to monitor their ABGs and labs. Hypokalemia. So this is usually going to be a potassium level less than 3.5. This is due to shift of potassium into the cells or potassium loss via renal excretion. So etiology is usually due to diuretics, renal tubular acidosis, where the potassium moves into the cells, GI losses like vomiting, diarrhea, or laxatives, right? We think about DKA also. How is this patient going to present? Ventricular arrhythmias, hypotension, cardiac arrest, malaise, skeletal muscle weakness, cramps. They can have ileus and constipation, polyuria, nocturia, and hyperglycemia. This is the one that's very commonly tested in regards to the EKG. So for hypokalemia, you're going to see a flat T wave and then a U wave. EKG, hypokalemia, potassium less than 3.5 or 2.5, depending on what book you're reading. EKG, flat T waves, you're going to see a U wave. So treatment for this, if it's patients asymptomatic, right, and they have mild hypokalemia, you can just give them oral potassium, right? If it's severe, you're going to give them IV potassium. Usually in the ICU where I work, all of our patients are sick and they're intubated, so I give them IV potassium, and usually our threshold is that we want anything higher than 3 for these patients. So usually I'll give them IV potassium. And usually these patients, it's not an emergency until they start having cardiac symptoms. And then you also want to make sure that you replace their magnesium because it stabilizes also the cardiac membrane. So usually if I have a patient that's in the ICU, and sometimes the nurse will be coming up to me and they're like, oh, they had like a minute of VTAC. And so I'll look at it, and then of course I'll go inside, go to the patient's room, assess the patient at bedside, just to make sure they look okay. And then the next thing I do is I'll get a BMP, so a basic metabolic profile, and then I'll look at their electrolytes. Usually if you give them magnesium, they improve a little bit. So that's why magnesium is really important. It stabilizes the cardiac membranes. Hyperkalemia is going to be a potassium level that's greater than 5.0. It's due to shift of potassium out of the cells or impaired excretion by the kidney, right? And this is very, very dangerous in comparison to hypokalemia and can become very rapidly fatal. So some of the causes of this, the common one's going to be renal failure, and usually in these patients they have like potassium of 5.2, 5.3, 5.6. I will treat the potassium urgently, and then I will try to get renal involved to see if they can get dialyzed. So usually these patients have renal failure, whether it's they missed dialysis or they're getting like an acute kidney injury because they're septic, right? Other causes can be hypoaldosteronism, cell death, tumor lysis, right, where the cell just dies and all the potassium shifts out of the cell. Metabolic acidosis, and then rhabdomyolysis is a big one that can cause hyperkalemia. How is this patient going to present with hyperkalemia? They're going to have fatigue, lethargy, muscle weakness, paresthesias, flaccid paralysis was one you have to know. Dysrhythmias, cardiac arrest, it can go into asystole. So once again, the ones you're going to see is flaccid paralysis or dysrhythmias, cardiac arrest, asystole. Diagnosis, you're going to do a BMP, right? You're going to look at the serum potassium. It's going to be greater than 5.0. You're going to get a BUN and creatinine, look at the renal function. EKG is what you have to get. This is where you're going to see peaking of T waves, right? You're going to see those peaked T waves literally look like mountains. And you'll see a prolonged PR interval with widened QRS. So treatment for these patients, the mnemonic is C big K drop. So C is going to be for calcium gluconate. That's going to be the first one you're going to give. And this is very, very highly tested, and it's very important that you know it, because if you're going to practice in the emergency room, urgent care, hospital list, or even like ICU, it's really important you know how to treat this. So the first thing you're going to do with these patients is going to give them calcium gluconate, right? And this is going to help stabilize that cell membrane, and that's why you give it. It's cardiac, right? You want to make sure you stabilize that cell membrane. Give them calcium gluconate. That's going to be the first thing. That's why it's C big K drop. The other thing you can do is K-exolate, although honestly that's kind of fallen out of favor, but just in regards to textbook-wise, do K-exolate. We don't use that in the hospital where I work at. You can do glucose also. You can do beta agonists like albuterol. What albuterol does is that it redistributes potassium, so it shifts it into the cell, the potassium into the cell. You can also do insulin and sodium bicarb, and that's what they do also. They redistribute that potassium and shift it into the cell. To eliminate the potassium, what you're going to do is you're going to do dialysis, where you're going to remove the potassium, and or diuretics like furosemide. That's going to increase renal excretion. So make sure you know these are very, very commonly tested. Hyperkalemia, those peaked T waves, right? Any potassium greater than 5.0, we think about usually renal failure with these patients, rhabdomyolysis, and like I discussed, we're going to get an EKG treatment. The first line you're going to do is C big K drop, right? C is you're going to do your calcium gluconate, not carbonate, gluconate. They try to trick you with that. Calcium gluconate works a lot faster, gluconate. So calcium gluconate, the first thing you're going to do, this is going to stabilize that cell membrane. It'll prevent any type of cardiac arrhythmias. The other things you can do is K-exolate and glucose, just for textbook-wise, right? Now, if it tells you what medications help redistribute potassium are going to help shift that potassium level into the cells. Now we're thinking about beta agonists. So you can do albuterol, insulin, and sodium bicarb. To eliminate the potassium, you can do things like dialysis or diuretics. Next one's going to be hyponatremia. So the level of sodium is usually between 135 to 145. And I'll be honest with you, I still struggle with hyponatremia as a practicing PA. And not only me, a lot of the residents that I'm with, we always struggle with hyponatremia. So I know it's going to take a long time for us to understand it, even though we've had it explained several times from our attending doctors. So sodium, 135 to 145 is normal. Usually anything less than 135 is considered hyponatremia. And what happens is that hyponatremia is just about water, right? So with hyponatremia, that means that you're losing more sodium than water, or you're gaining more water than sodium because it's water. Think about water. And it's based on the patient's volume status. So you have different types of hyponatremia. You have isotonic, hypertonic, and hypotonic. So isotonic, usually this is going to be in patients that have high triglyceride levels or protein in their plasma. This results from the lab usually. Hypertonic, this is usually an increased tonicity in the extracellular fluid. And in extracellular fluid, what happens is that it increases, but usually the sodium is constant. So you want to make sure that you correct any type of underlying problem. And then hypotonic is going to be definitely the most common type you're going to see, 90% of hyponatremia. So let's go into the 3 different types that fall under the umbrella of hypotonic hyponatremia. So we have a hypovolemic. This is where you're losing both water and sodium loss, right? But you're having larger decreases in sodium as compared to water. So examples of this are going to be diarrhea and vomiting, dehydration, diuretics like hydrochlorothiazide, right? Burns, where you're losing a lot of fluid, aldosterone deficiency, cerebral salt wasting syndrome, which is one of the things I see a lot in the ICU, and I have to differentiate that between SIADH. And then usually with these patients, you want to make sure that you replace the normal setting slowly, right? Because if you overcorrect it, you can make the patient herniate. Hypervolemic is going to be the other type of hypotonic hyponatremia. So hypervolemic, we think about that there's an increase in sodium and water in the extracellular fluid. It causes sodium to move into the intracellular compartment, and what happens is that you have large increases in water and you have small increases in sodium. So examples of this is going to be anything where you have a lot of fluid, right? Cirrhosis, congestive heart failure, nephrotic syndrome, kidney disease. Usually these patients, you're going to see a lot of edema. They're going to be fluid overloaded. And treatment is to, for example, fluid restrict them and water restrict them. Euvolemic hyponatremia, usually these patients have no change in sodium, but they have increase in water volume. So usually they'll have normal sodium, so no edema. Examples of this is going to be SIADH, hypothyroidism, polydipsia, beer potomania, which is where the patient's drinking a lot of beer. And then patients that have certain types of cancers, exercise. Treatment's going to be water restriction, and you want to make sure that you differentiate which type it is with the urine concentration. If the urine's way too concentrated, then we're thinking about syndrome of inappropriate antidiuretic hormone, or how my attending calls it, excess ADH, because there's no such thing as inappropriate antidiuretic hormones. There's just excess ADH. So if it helps you memorize it and remember it, hopefully it's helpful for you. So if the urine's concentrated, then we're thinking about SIADH. If it's dilute, that means there's too much fluid. Okay, the next one's going to be pseudohyponatremia. This is where the patient has normal sodium and water. It's usually seen in hypertriglyceridemia and multiple myeloma. And then how is this patient just in general with hyponatremia going to present? So they're going to have nausea and vomiting, altered mental status, paresthesias, muscle cramps. If it's severe, if they have a sodium level less than 120, they can have cerebral edema. They can have headache, increased intracranial pressure, confusion, obtundation, seizure, coma, and death. So it's really important that you don't correct the sodium rapidly, because it can lead to what? Central pontine myelinosis. So it's really, that's what you need to know. Do not correct it quickly. So do not correct it in my ICU more than 10 by 10 in 24 hours. So if you have a patient that's like 115, for example, you don't want to correct them to like 129, because then everyone starts freaking out, and that's when we get renal involved, and the renal starts going crazy about the sodium level, and it's just crazy. So the next one's going to be hypernatremia. It's going to be the opposite, sodium level greater than 145. Like I said, this is with sodium, it's usually a problem with water. So with these patients, they're losing too much water than sodium. So there's usually due to renal losses, or they're gaining more sodium than water. So causes of this is going to be water deficits, exercise, overingestion of sodium, whether it's through IV or diet, central diabetes insipidus, right? This is usually driven by antidiuretic hormone. And then treatment, how is this patient going to present? The mnemonic SALT, SALT. S is going to be skin flushed, A is going to be agitation, L is going to be low-grade fever, and T is going to be thirst. It's going to be the main symptom you're going to see. It's going to be a main defense. Neurological symptoms you can see with these patients: altered mental status, seizures, coma, and hypovolemia. Treatment is going to be just correcting the underlying disorder, gradual fluid replacement, monitor for cerebral edema, monitor sodium, and then of course seizure precautions. So hypocalcemia. So calcium levels, we think about 8.5 to 10.5. So anything lower than 8.5, we think about hypocalcemia. Anything greater than 10.5, we think about hypercalcemia. So hypocalcemia is going to be a calcium level less than 8.5. Etiology, we think about renal failure. Vitamin D deficiency is one of the big ones also. Suppression of the parathyroid hormone, so hypoparathyroidism. Hypersecretion of calcitonin, malabsorption, intestinal acidity, infection, or low magnesium. This patient is going to be presenting with muscle cramping, spasms. This is something that's very commonly tested and you have to know. So we think about Trousseau-sign and Chavoskit's sign, right? Trousseau-sign is where you have the blood pressure cuff and you're pumping it and you have this flexion of your arm. And then you also have your other sign, which is going to be your Chavoskit's, right? That's where you have the twitching of the cheek whenever you tap on it. Paresthesias, increased deep tendon reflexes, seizures, confusion, and dementia. Diagnosis, you want to make sure you get an ionized calcium, magnesium. You want to make sure that you get an albumin level, LFTs, amylase and lipase, and BU and creatinine. Also an EKG. On EKG, you're going to see prolonged QT. It's really important that you know how these look on EKG because they're going to test you for hyperkalemia, hypokalemia, hypercalcemia, and hypocalcemia, okay? So hypocalcemia, you're going to see a prolonged QT. Treatment, if it's severe hypocalcemia, then you want to make sure you give them IV calcium gluconate or calcium chloride. If it's mild, you can give them something like oral calcium and vitamin D, and then make sure you educate the patient on increasing their diet and having calcium in their diet. So hypercalcemia is going to be a calcium level greater than 10.5. Etiology of this is going to be hyperparathyroidism, hypothyroidism, renal disease, milk alkali syndrome, vitamin D excess, medications like thiazides and lithium, and then cancer. Usually these patients are asymptomatic until the calcium is like very high. Usually what we think about is going to be symptoms that are associated with hyperparathyroidism, right? We think about our stones, which are going to be your kidney stones, moans, which is going to be just pain, bone pain, groans, and psychiatric overtones, right? Usually where the patient's suppressed, have change in their mental status, groans, constipation. So diagnosis, you're going to get an ionized calcium, once again, magnesium, albumins, LFT, amylase, lipase, BU, and creatinine. You can also get a parathyroid hormone level and then a bone scan. And then once again on the EKG, you're going to see short QT interval because it's hypercalcemia versus hypocalcemia. You're going to see a prolonged QT interval. So treatment for hypercalcemia is going to be isotonic saline, normal saline, loop diuretics. Manage whatever is the underlying cause. If it's hyperparathyroidism, then you have to make sure you manage that. Diet restriction, calcitonin, and you can do something like biphosphonates. All right, so I hope this video was helpful for you. Like I said, I think the thing about studying for the PANCE is repetition. So if you can use this video in conjunction with flashcards, flashcards for me were definitely a lifesaver because repetition is a key. If you just sit there and you read everything and are not quizzing and testing yourself, then how are you going to know if you actually know the information? So repetition is a key, and the reason why I made these videos is to help for those of you who are busy, if you're working out, if you're cleaning your house, if you're walking, if you're driving. Hopefully these videos are helpful. Just listening and just repetition is going to help you pass the PANCE. All right, hopefully this video is helpful for you. If I made any mistakes, please let me know. I try to do my best with my notes, but I know sometimes there might be any mistakes, so comment below. Please let me know. Also, if you have any feedback for me, how I can better improve these videos. I'm hoping on getting a better camera so I can get better video quality for you guys. And then also, if you have any cool mnemonics, like mud piles, for example, for diabetic ketoacidosis, right? Any cool mnemonics for other students to learn or PAs that already graduated, please let us know. All right. As always, thanks for watching my videos, and I'll talk to you guys later. Bye.